Belum terima apa-apa gitu.
That's a good question. Recording now. See, the light, they got a red light in front. Yeah.
Anatomy of the brainstem? You have already mentioned, right? So how many parts in brainstem? What are they? Midbrain? Bone? Yeah, okay. So what is the overall function of brainstem? A balancing coordination, okay? Then next, voluntary acting hand. Is it brainstem is essential for life or not?
Yes.
If patient is cerebral cortex is damaged, is the patient die? No. Okay. So it is called cerebral cortex cannot function no more, but brainstem still. So it is called no brain dead. It is called comatose. But the brainstem dead, brain dead. So means that brain dead means totally dead. So means that if the brainstem still function, the patient still survive, but the survival is vegetative life. You know the vegetative life coma patient on the bed. You have to make all the nursing care. But the thing is, because of the brainstem still function, they have control of blood pressure, respiration, all the vital functions are still because of brainstem function. But not cerebral function no more, so the patient has no more awareness, but still survive. So brainstem is a major basic function, controlling of the respiration, controlling of the blood pressure, okay? Because you know, for example, in the emergency, patient came to the emergency, what the doctor check for the first one? What are the vital? What are the vital for the survival? The first one is ABC. Airway. Okay. Oxygen. If the patient can survive, oxygen level is good. Okay. B is breathing. Respiration is normal or not? Circulation, we check for the blood pressure. Okay, this three okay. Okay, this is the mean the survival. This survival is maintained by the control center is at the brainstem. If the brainstem damaged, gone, everything gone. Cannot, totally cannot. Understand? So it is very basic life support for the survival of the patient. So 121 is the column. Okay, I will show again other dimension. Or still. Or 23, or still 23. Brainstem. Okay, so this is the learning objective. Okay, this is the learning objective. Okay, the first is the functional organizations of the three major components you already mentioned: midbrain, pons, and medulla. Functions of the each component of the brainstem. And then what about the brainstem, cranial nerve, nuclei, and what about their role in the reflex pathway in terms of the pupillary light reflex, visual, fixation reflex, and posture reflexes. And what about the role of brainstem, nuclei in the motor function of our body and also the sensory analysis? What about the reticular formation? Okay. So brainstem. See here, this is the brainstem. Okay, so we start with that. This is the midbrain. This positive portion is the pons. This is the medulla oblongata. Okay, so pons and medulla oblongata together is the hindbrain. Okay, so this is the front and below one. See here, this is cranial nerve. This is all the cranial nerve are coming out from the brainstem. Okay, So see here, this is the palm, this is the pyramid, no? This is the pyramid, no? You have this is the pyramid. No? Okay, so this is the thalamus, this is the optic, no? This is the trochlea, this is the hypothalamus area, no? Hypoglossal nerve, no? Vagal, glossopharyngeal, vestibular fascia, abducens. So many nerves are coming out from the brainstem. Okay. So, no? The brainstem is the vital link between the spinal cord and higher brain area. So all incoming means sensory form, no? Carry the impulses, no? All incoming and outgoing is the controlling for the motor activity, no? They are passing through the brainstem from the periphery to the brain, from the brain to the periphery, no? So pass through the brainstem. So the incoming fiber means they carry the sensory information to the brainstem. Outgoing fiber means they carry the motor information from the brain to the effector organ. Okay, so this is the brainstem, no? This is the palm, medulla oblongata, the midbrain. Okay, so this is the major functions of the brainstem. So for the exam point of view, you have 4 types of questions from here, not 4 types, so many. Okay, the first one is the brainstem function. So brainstem function means I ask you overall function. Overall, they have the 5 functions. This is the overall function. Sometimes I ask you with the individual function. Individual is what is the functions of the brain, what is the functions of palm, what is the functions of medulla oblongata. So in terms of individual function, I can also ask you. So we have four questions. Okay. This is the overall function. The first one is I already mentioned. It is like the relay center. It will pass through that sensory, pass through the motor. So it starts as a conductive function, no? Conductive pathway, no? Conductive function. And then so many cranial nerves are coming out from the brainstem. So it also functions as a cranial nerve function. And I have already mentioned all the important control centers are located in the brain. So we have the integrated function for the vital, because of the vital control area, centers are located within the brainstem. And then fourth function is controlling of the muscle, reflexes, muscle control. And then fifth function is reticular formation. Reticular formation means, you know that I have lecture on the year 1, RAS system, reticular activating system. The RAS system? What RAS system? RAS system is concerned with our body. Our body. RAS is reticular activating system is for alertness condition. For example, fight or flight. You have must to run away from that area. Fight or flight. RAS system is very activated, right? Okay. So this RAS system, the whole RAS system control center is along the brainstem. Okay, so brainstem is very much important for that RAS control, reticular activating system, because the whole RAS formation is along the brainstem. Okay, so the first one, this is for the detail. And in the exam, if I ask briefly describe the functions of brainstem, you cannot stop in here, no? You cannot stop in here. This is only the title. You have to mention for the detail, okay? Detail not very detailed, it depends on the marks, no? But you need 1 to 2 explanations for each function. Otherwise, how I get the marks, right? Okay, so the first one is the conductive function. So conductive function is it relates sensory fiber, motor fiber. No? So the only way for ascending sensory form, not try to reach the thalamus, cerebrum, and cerebellum. This is ascending, right? Okay, these are the descending, not to the spinal cord. Okay. And also the descending motor try to reach the spinal cord is through the brainstem. So they serve as a conductive pathway relay center. Okay. Second is the cranial nerve. No? Majority of the 12 balls of cranial nerve are arising from the brainstem. They supply the structure in the head and neck. Most of the cranial nerve, no, coming out from the brainstem, they mainly supply the structures of the head and neck, except 10 cranial nerve, vagus nerve. Vagus nerve is control that. Vagus nerve is very much important for which area? Vagus. 10 cranial nerve. Abdomen, no? So vagus nerve is very much important for the abdomen, gastrointestinal system. No? For the gastrointestinal system, vagus nerve, we call the name for the vagus nerve is secretomotor nerve. Secretomotor nerve means vagus nerve control the secretion of all the GI tract, increase secretion. Motor nerve increase motility of the GI tract. Vagus, no? So vagus is which neurotransmitter is the vagus nerve? Vagus nerve coming out which neurotransmitter? Which neurotransmitter? Noradrenaline. Acetylcholine. Which one? Which one? Vagus nerve. Acetylcholine, no? Acetylcholine. So the functions of the acetylcholine on the GI tract is increase secretion, increase motility. Because of this is the vagus control, right? Okay, okay, so see here, this is the majority of the troubles of cranial nerve are coming out from the brainstem. So the supply, the structure in the head and neck, not like the motor and sensory fiber for the sight, hearing. These are the special sense, but not taste, smell. Also the sensations of the face, scalp, eye movement, twitch, swallowing, facial expression, muscles of facial expression. Supplied by which nerve? Which cranial nerve? Muscles of facial expression supplied by which cranial nerve? Facial expression, facial nerve. Okay. And then for the salivation, exception is this one, 10 cranial nerve. Even though it is coming out from the brainstem, it's controlled at thoracic and abdomen. You know, major is abdomen. Okay. See here, a lot of nuclei, no, cranial nerve nuclei are along the spinal cord. Okay. At the various brainstem level. Okay. See here, the third one is the integrated I already mentioned. The vital center, especially at the medulla. Medulla is mostly controlled with the blood pressure control. So this is the blood pressure control. This is the sensory fiber from the carotid sinus, aortic arch. Okay, carotid sinus is the receptor, aortic arch, not coming out from the arch of the aorta. This is also the sensory receptor. They are called the stretch receptor. Stretch receptor means these receptors are activated when their location is stretched. Why their location is stretched? Because they are located in the carotid sinus and aortic arch. These blood vessels are stretched. Stretch means they increase blood volume. They increase blood volume means they have high blood pressure. So means that they are activated when the blood pressure is increased. Okay, because sometimes the children, they study like they start with the carotid sinus and aortic arch. But in the exam, sometimes we ask the condition, these receptor carotid sinus aortic arch start to activate. But the condition is increased blood pressure or decreased blood pressure. Increased blood pressure because of their stretch receptors. Okay, so they are carried by the 9th and 10th cranial nerve, glossopharyngeal. This is the vagus. Glossopharyngeal is from the carotid sinus. This is from the 10th cranial nerve from the aortic arch, and then they reach to the medulla oblongata. Okay, this is the afferent nerve, which is the medulla oblongata. So by means of the interneural nerve tract, and then they reach to the spinal cord, and from the spinal cord, this is the motor fiber. So they make the impulse whether the blood pressure is increased. So blood pressure is increased, they have the opposite of no. Or they make that if the blood pressure is increased, they start the firing rate, means that they have the increased distance, and then finally is they decrease the heart rate, and also the vasodilation of the arteriole. And then the medulla oblongata is for important is for what? Medulla oblongata, adrenal medulla is for what? For the category adrenaline, noradrenaline, dopamine secretion decrease because they are sympathetic. So means that if the blood pressure is increased, inhibit. So vasodilation, or the category secretion decrease, so it causes vasodilation because category is a vasoconstrictor. Okay, and then for the heart rate decrease, bradycardia. So blood pressure back to normal. So what happened to the blood pressure is decreased. So blood pressure is decreased, they have no impulses, all these activities are activated for. So this is overall for the blood pressure control, okay? And then next is this is the pond. Pond has also the important control center for respiration. See here, this is the pneumotaxic center. This is the apneuristic center. Rhythmic center is normal rate of respiration. They are controlled at the pond. Okay, so reticular. See here, this is the whole is the reticular formation. This purple color. So they are along the brainstem. So brainstem is very much important for the temperature control, respiration control, right? Okay. So the fourth function is brainstem regulate the muscle reflexes. They are important for the posture, equilibrium, and the fifth function is the RES for reticular formation because it's located throughout the entire brainstem until to the thalamus. They receive and integrated all the sensory synapses, and then from this RES reticular formation area carries signal upward the whole cerebral cortex for the arouse and activate for the alertness. Okay, cannot stop in here. They reach until the cerebral cortex because alertness is we need for the awareness. So awareness means all the signals are reached to the cerebral cortex. So for the awareness, for the conscious, we definitely require cerebral cortex. Okay, because I have lecture right. Already done for the thinking, memory, they are done from the cerebral cortex. All are function, okay, but for the awareness is from the cerebral cortex, okay? So, overall control of the degrees of cortical alertness and important ability to direct the attention, RES is alertness. Okay, so and then here is the other functions of brainstem, overall functions of brainstem, okay? Next, now what about the significance of brainstem function? I already mentioned before the class start. Severe brain damage, coma, loss of functions of entire brain, cerebral cortex lost, totally gone. However, brainstem persists, thalamus persists. So means that they can control the life-sustaining process. Sleep, body temperature regulation, breathing, circulation, digestion, all are still persist. But the patient has no awareness, no feeling, so it is called the vegetative function. Vegetative life is the coma patient. They can urinate, everything function, but no awareness. Right? So this is called the vegetative function. So you need to make the nourishment, skilled nursing care support. You have to change the position every hourly. Adequate body care still functions and survival because of the brainstem is still persists. That the person has no awareness of the control of the life, so this is called the vegetative life. This is the significance of brainstem function. Okay, and then next is the what is the role of brainstem in the motor function? Actually, regarding for the motor function, motor function alone is not controlled alone from the brainstem. Actually, for the CNS, all the functions are integrated. So motor is also controlled from the brainstem, as well as from the cerebral cortex, also the cerebellum, also the basal ganglia, all are combination. So if the one area is damaged, the problem is still respond and continue the function, but their functions are not proper, not detailed. Right? Okay. So brainstem also involved in the motor function. Brainstem contains the neural circuit for the initiation, the locomotion, and control of the posture. So the maintenance of the posture requires the coordinating activities of both axial and peripheral muscle. You know the axial muscle, peripheral muscle. What is the axial muscle? Axial muscle is actually the center, right? So the axial muscle control is for the walking, climbing, walking, maintaining the equilibrium. This is the axial muscle control. What is the peripheral muscle control? Peripheral is for the fine-scale movement, like writing. This is the peripheral muscle control. Okay? So, means that maintenance of the posture is required, the activity for both axial and peripheral. So they receive the input from the proprioceptors. Proprioceptor is from where? Receptor from where? Proprioceptor. Where? Proprioceptor. Brain. Abdomen. Where proprioceptor? Joint position stand. joint position sense. For example, running. So you have running, walking, you have so many joint movement, right? So at the time, proprioceptor has the awareness. They make these changes. They are carried the impulses. They are starting with because they are receptor for joint position sense, proprioceptor. And the spatial position. Spatial position is the body position in the space. Either whether am I in standing position or sitting position or lying position. Okay, so this is the position sensor. They are made from the inner ear. Okay, so they are concerned with the maintenance of the posture. So they are required for the brainstem activity. And then cerebral motor through the vertebrospinal system is necessary for the control of individual movements of the distal limb, also the digit, hand digit movement. And then each higher levels of the nervous system act on the lower level to produce appropriate move, right? I already mentioned. We start with the higher function and then control the lower function. Okay. Okay, so how we make the motor function? Regarding for the motor functioning, I already mentioned you have many motor control. So these motor controls are coming out from these 5 major centers to control our whole body motor function. You must know this control of the motor function. The first area is premotor or primary motor cortex. The second is the basal ganglion. I have lecture tomorrow. And then next motor control is cerebellum. They have the specific one. For example, cerebellum is concerned with the balance, maintenance of the equilibrium. Okay, like that. And then the brainstem also involved in the motor function because a lot of nuclei, reticular nuclei, red nuclei, vestibular nuclei. Okay, vestibular nuclei is within the inner ear. And then also they have a lot of designing motor tract. Motor tract controlling motor activity, perimeter tract, extrapyramidal tract. The combination is begun. Find a common pathway. These all are control of the motor function. Okay. So what are the motor control area? The first one is premotor or primary motor cortex. The second area, and then cerebellum, and then brainstem nuclei. The final is zenimotor tract. Okay. The first is the extrapyramidal system. Our body has a motor system, motor tract. We can divide it into 2. The first one is the pyramidal, the second is the extrapyramidal. For the pyramidal system, I will mention my next lecture for motor lecture. Motor lecture, I will mention detail for the pyramidal tract. In here, I will mention for the extrapyramidal tract. So what is the pyramidal tract, extrapyramidal tract? They all are motor fiber concerning with the motor function. Okay, so why they call? Do you know why they call pyramidal tract? Why they call extrapyramidal tract? Why they call the extrapyramidal tract or extrapyramidal system? Extrapyramidal means extra is outside. You know the pyramid? Remember pyramid? The fiber pass through the pyramid body. Pyramidal tract, or the fiber doesn't pass through the pyramid, it's called the extrapyramidal tract. That's all. Okay? But they have separate function. But both tracts are important for the motor control. Okay? Actually, they both are combined function. Okay, so see in here, this lecture I will mention detail for the extrapyramidal system. So extrapyramidal system, extrapyramidal motor tract originate in the brainstem because it is more concerning with the brainstem. So initiation of the body movement, maintenance of posture, control of the muscle of the facial expressions and other functions. Okay, so if the pyramidal tract of the extrapyramidal tract of the experimental animal is damaged, we cannot test CNS experiment in the human because we have to destroy this specific area. You see, I already mentioned all the CNS control are integrated function. So you cannot know this is the the functions of pyramid, this is the functions of extrapyramidal, because we cannot test in the human being. We can only test in the animal. If you want to see the detailed functions of the extrapyramidal tract, you have to describe the pyramidal tract. Otherwise, all the functions are combined. How you know, how you differentiate. So normally we test that. All the CNS functions are in the extrapyramidal animal. So if we remove the extrapyramidal tract, or maybe we remove the pyramidal tract, no? If the pyramidal tract of the extrapyramidal animals are cut, after that you give the stimulation to that animal, whether any response or not. No? So the stimulation from the cerebral cortex, cerebellum, basal nuclei shall produce movement because of they are carried by the extrapyramidal motor tract. But the thing is, these movements are not very coordinated and not very fine and proper movement because they have only extrapyramidal. They have not combination for proper control. Okay? Okay, so this is the three extrapyramidal tract. I will mention these three for detail. So they are concerned with the motor pathway, especially for the posture, voluntary movement. Majority of the nuclei are coming out from the brainstem. Okay, so the first one is vestibulospinal tract. Vestibulospinal tract. See here, this is terminology. The fiber is coming from the vestibule until spinal cord. So they call vestibulospinal tract. So where is the vestibule? Where? Where is the vestibule? Where? In the ear leg? You see? Vestibular apparatus there. Okay. So vestibule until the spinal cord. Not for the vestibular nuclei. Vestibular nuclei. Okay. So it's coming out from the vestibular nuclei in the brainstem. This is the nuclei. Okay. See here. Okay. See here. This is the vestibular nuclei. Actually, vestibular nuclei area we have the two area. No. This is the first area. This is the second area. Okay, so this is the vestibular nuclei. I will mention detail. No, this is the vestibular nuclei. So this is called the vestibulospinal tract. Okay, so next is the rubrospinal tract. Rubro is red nucleus. Okay, so the fiber from the red nucleus is called the rubrospinal tract. Okay, and then reticulospinal tract from the reticular formation. Reticular formation is the big area. So this area. So from the reticular formation is the reticulospinal tract. Okay, so they all are extrapyramidal tract. Okay, so what about the function? Okay, vestibulospinal and reticulospinal. Okay, so see this is red color, this is brown red color. So what is the significance? Red color is the excitatory pathway, excitation. No? This is the inhibition pathway. Okay, so vestibulospinal. See here. This is the vestibulospinal, and then this is the vestibulospinal tract. See here. Okay, so see here. This is the reticulospinal tract. So for the reticulospinal tract, we have two. Reticulospinal tract coming from the medulla. Reticulospinal tract coming from the pons. So this is for the medullary reticulospinal tract. This is for the pontine reticulospinal tract. So what is the difference between the two tracts? What is the difference? What is the difference? Yeah. Medullary and pontine reticulospinal tract. The difference is, hey, you see the color? The color. The red color is for excitation. So means that this one is pontine reticulospinal tract, concerned with the excitatory pathway, and medullary reticulospinal tract is inhibitory pathway. This is the overall. If I ask in the MCQ, you know lah. So this one is the pontine is the excitatory. Don't need to remember for both. If you remember for the one, the opposite is opposite. Okay, right? Okay, so vestibulospinal, this is the vestibulospinal. Right? Also the reticulospinal is the they all are influenced motor neuron control the axial muscle, not center muscle. And as well as the proximal limb muscle. You know that what is the proximal, what is the distal? So this is the proximal muscle. This is the distal muscle. Okay. And then next is the rubrospinal. spinal. No? Rubrospinal is the excitatory. Rubrospinal is, you see here, compared with the fiber, rubrospinal tract location is a little bit more periphery because they are located in the medially descending motor. So this is a little bit lateral. So they are concerned with the distal control muscle. Because location is distal, so their control is distal. Okay. Rubrospinal tract influence the motor component of the distal. This is the overall. If you know this one, it's okay. But okay, I want more higher marks, you need to detail. Okay. So this is the overall, starting from the control center, motor. You see here, all are descending fibers pass through the brainstem, the brain-pons, medulla. Actually, these all are upper motor neuron. Okay, and then they all are finally stopped in the spinal cord. From the spinal cord, they are concerned with the fiber by means of the lower motor neuron. Okay, so what are the lower motor neurons? I will mention today on my next lecture. Lower motor neurons are alpha motor neurons, see here, and gamma motor neuron. So what are the difference between the alpha and gamma? Alpha motor neuron, gamma motor neuron, they all are directly control the muscle. Okay, see here, I call you the alpha motor neuron, lower motor neuron. Okay. What is the difference between the alpha motor neuron and lower motor neuron? Actually, alpha motor neuron control the activities of the lower motor neuron. The lower motor neuron is they directly communicate with the muscle. So means that if lower motor neuron damage, upper motor neuron still function, but their functions are out of control. Okay? So, what happened to the lower motor neuron damage? Lower motor neuron damage, this lower motor neuron is directly communicating with the muscle. So, higher center is give whatever they give the order, but directly is the lower motor neuron. So, the muscle cannot function, even though the higher function. Okay? So, like that. Okay? So, this is the lower motor neuron of the alpha gamma. Okay? So the first one is the rubrospinal tract. Okay. Okay, so we are here. Rubrospinal tract. Okay, so rubrospinal tract is motor tract coming from where? Where? Red nucleus. Rubrospinal tract is coming from the red nucleus. So coming from the red nucleus, no, receive the major input. You know, in here I mentioned two types of fiber, afferent fiber, efferent fiber. Afferent means regarding for the sensory information. The fiber carry all the information to that area. So it is at that time I say the afferent fiber. For example, in here, for the red nucleus, the fiber coming to this red nucleus all are afferent fiber. And the fiber coming out from that red nucleus is called the efferent fiber. Okay? So the red nucleus receives the major input from the cerebral cortex and motor fiber. So the fibers coming from this area are afferent fiber because they are entered into the red nucleus. From the red nucleus, they are outward fiber, they are efferent fiber. No? So this efferent fiber is coming out from the red nucleus, then directed to the contralateral. You know the contralateral is the same for opposite side? Contralateral, same for opposite side. No? They reach to the opposite spinal motor neuron and then control the distending muscle. No? So the axons are located in the lateral spinal white matter, anterior to the, very close to the corticospinal tract. This is the pyramidal tract. So the functions of the cerebrospinal tract is they control the limb flexor muscle. So what is the flexor muscle? Flexion, not flexion. So they are concerned with the flexion. So they are control the flexion, at the same time they are stimulate the function, at the same time they inhibit the extension. You know? So inhibit the extensor muscle. No? So they influence the gamma motor neuron function. Okay, this is the cerebrospinal tract, no? From the red nucleus. Okay. And then next is the reticulospinal tract. Reticulospinal tract. No? See here, this is also afferent, also the efferent fiber. Okay, efferent. No? So the afferent fiber through the reticulospinal tract is from spinal cord, vestibular nuclei, cerebellum, lateral hypothalamus, globus pallidus. You know where the globus pallidus? Where? Basic ganglion. Okay. And the dectum and sensory motor cortex. This is the afferent, and then from this afferent fiber, they lead to the reticular formation. Already mentioned, we have the two control area for the reticulospinal tract. The one is from the fore, the one is from the medulla. So pontine fibers are concerning with the excitatory action potential. They control the axial muscle control. No? Reticular is axial. And then medullary reticular fiber is concerned with the inhibitory control. No? They have control on the extensor motor neuron. And then that is the vestibulospinal. No? Vestibulospinal is concerned with the vestibule. No? So the afferents are from the vestibular portions of the inner ear, and they are concerned with the rotatory linear motions of the head and body. So they are important for the maintenance of the postures and balance. Also, they receive the input from the retina, because for the position, the maintenance of our body position is also, we need input from the eye. No? So retina also receives an adjusting eye position during the movement of the head. What happens if these areas are damaged, these tracts are damaged? So the patient reduces the muscle tone, especially for the external muscle of the limb tract. So difficulty for the walking, maintenance of the upright position. Okay. So I have done for 3 tracts. So this is the overall classifications for all the descending motor tract. Okay. So how many motor tracts? We have how many motor tracts? Okay, so this is the lateral corticospinal, anterior corticospinal. They are pyramidal tract. I will mention in next lecture. Okay, their origin is cerebral cortex. Lateral is cross the midline. This one doesn't cross the midline, but finally cross at the spinal cord level. I already mentioned is 3: cerebrospinal, vestibulospinal, reticulospinal. All are extrapyramidal fiber. So this one is starting from red nucleus, vestibular formation, crosses only cerebrospinal. Remember, cerebrospinal is cross. No? So cross means they have the opposite control. No? Okay. So this is regarding for each component. So regarding for the fiber already done. So this is the what is the functions of midbrain, what is the functions of paw, what is the functions of medulla oblongata. Okay, so we start with the midbrain. Midbrain consists of superior and inferior colliculi, dorsally, cerebrospinal, ventrally. You know anatomy, right? Okay. Also, it has a red nucleus. I already mentioned. Before red nucleus is called the afferent fiber. After red nucleus is called the efferent fiber. So the name of the efferent fiber is dentate to rural fiber, from the dentate nucleus to the red nucleus. Okay? So they are coming from the contralateral, means opposite hemisphere, and then reach to the red nucleus. When they reach to the red nucleus, the fiber coming from the red nucleus is called the cerebrospinal tract. They cross again, and they execute in the direct movement. No? Cerebellar posture control on that. Ipsilateral side. Ipsilateral is the same side control. Means that afferent fibers are coming from the opposite hemisphere, reach to the red nucleus. After integrating as a red nucleus, they cross again to their original position. So means that their control is is similar at the same time, not because it is the double cross. Okay? And then what about the functions of midbrain? Because of they have superior inferior colliculi. Superior colliculi is concerned with vision, control of vision. Inferior colliculi is control of hearing. Okay? Okay, so this is the control center for the midbrain. And then cerebral median is concerned with the tract, not ascending tract, descending tract. And then red nucleus is important for the fine-scale motor movement. These are the functions of the midbrain. Okay? Okay, so this is the midbrain. This is the red nucleus. Okay, this is the afferent dentatorubral fiber. This is the dentate nucleus. Dentatorubral fiber, they reach to the nucleus, and the outgoing fiber is called the. This is the whole reticular formation. This is outgoing is the rubro under the spinal cord. This is the efferent fiber, rubrospinal tract. This is the afferent, this is the efferent. Okay? Okay? Okay, so what is the function of midbrain? The first function is cranial nerve function because it has third cranial nerve. So, what is the third cranial nerve? Third cranial nerve is object is second. Third is oculomotor. Okay. So they have the pupillary light reflex. They have the eye control movement, controls of visual fixation or not. You fix the vision. Okay, and then also the control for the posterior reflected, writing reflected, vestibular placing reaction. I will mention detail in next lecture. Okay. So in this lecture, I will mention detail for the pupillary light reflex. Okay. So what is pupillary light reflex? If you use the bandage, you have the bandage, and if you shine one of your eye, what will happen? Pupil constriction. Okay, pupil constriction. Okay, if you shine the, for example, right pupil, this right pupil constriction, this is called the right light reflex. Okay, if you shine the light to the right side, the right pupil constrict. At the same time, what about the left pupil? Also constrict. But the response from the left pupil is called indirect or consensual light reflex. Why? Because we have only one sensory fiber, two motor fiber at the same time for both eyes. Okay? So we call that direct light reflex, consensual light reflex. Okay? So when the light is directed onto one eye, pupil of that eye constrict, it is called, you see here, this is the pupil constriction of the pupil dilate. You can check yourself. It is very obvious. Okay, so this is the, it's better use the pen dots, no? Not the big dots. Okay, so this is for the direct light reflex. Okay, so you see here, this is the pathway. So if you give the stimulus to that eye, this is the left eye one, no? If you give the light to the left eye, what will happen? Pupil constriction of the left as well as right eye. Okay, see here, this is the green color is the sensory fiber, carry the sensation. This is the optic nerve, this is the second cranial nerve. So sensory is carried by the second cranial nerve. Okay, carry this light stimulus, okay, and then LDN is lateral geniculate nuclei. Lateral geniculate nuclei. Some of the fibers I will mention details regarding for my future lecture. So some of the fibers are reached to the lateral geniculate nuclei. We have the lateral geniculate nuclei, medial geniculate nuclei, right? Lateral geniculate is concerned with vision, medial is hearing. Okay, so some of the fibers are reached to the LDN, and most of the fibers are reached to the midbrain. This is the midbrain. Okay, So midbrain control center area called predictor area. See here, predictor area of the midbrain. This is the integrating center, control center. From the predictor area, two fibers are coming up. You know, here is only one fiber. When integrated, after integrated at the predictor area, there are two fibers. So these two fibers reach to the each side. See here. So this nucleus is called Edingar. E that means Edingar was pearl nuclei. So from the predictor area, both fibers are again reach to the Edingar was pearl nucleus of each side. From this Edingar was pearl nuclei, there is the third cranial nerve. It is called oculomotor nerve. Oculomotor nerve is concerned with the motor function. Their motor function is they constrict the pupil muscle. So constriction is on both sides. So even though you give the stimulus to this side, the response is both eye is constriction. So normally if we check for the pupillary light reflex, we use the couple. You see? For the indications of the couple, we give the stimuli only one eye. You prevent with the couple to the other eye. Means that we only give the stimulus to one eye only, but the response is both eye constriction. Because we don't want the stimulus to the other eye, so we use the double. And we show only the one side. But the response is both sides. You can check for the patient for the both sides. So the right side is the direct light reflex, but the other side, if you check, the other side will also constrict is the consensual or indirect light reflex. Okay. So what are the condition impairments of these conditions? Impaired. So impairments of the direct light reflex. So what are the impairment sites? We have many areas. The first one is ipsilateral is the same side optic nerve. Even though you give the stimulus, this optic nerve is totally damaged. Cannot. Because cannot carry the impulses. So optic nerve same side is damaged. So impaired vision, or maybe predictor area damage, or maybe ipsilateral is the same side. Same side, because this is only the direct one. Same side, third cranial nerve impaired. Third cranial nerve problem. In here we say it is the parasympathetic traveling because they are stopped in the parasympathetic ganglion. So we say the parasympathetic third cranial nerve impaired, or maybe your pupil constrictor muscle cannot function well. So they all are possible damage of the impairments of the test. Okay? Okay? So next is the indirect or consensual light reflex. One eye is directed into one eye. This is direct. Okay? Causes the opposite pupil to constrict. So this is called the consensual light reflex. This is direct. This is the consensual light reflex. Okay? So consensual light reflex is impaired in the lesions of contralateral optic nerve. Okay, see here. Consensual is you give the stimulus to that eye. You check the response to that eye, right side. Okay, so even though you give the stimulus, this one is constriction, this one cannot constrict, maybe kinase. So the problem is contralateral optic nerve. Means that impulses totally cannot carried by the optic nerve. Also can. Why say contralateral? Because this is a subject for this case. So in terms of display, this is the contralateral side. Whenever you give the stimulus, this optic nerve totally cannot function. How the stimulus reaches to that area? Okay, so the contralateral optic nerve, also the predictor area, also the ipsilateral is their third cranial nerve problem itself. Or maybe they are itself tubular constrictor muscle control. So you understand what are the impairment sites of the direct light reflex, consensual light reflex. What is the direct light reflex? What is the consensual light reflex? Understand? Okay. Okay, so this one is very much important. Okay, so what is the pathway for the pupillary light effect? This is previously, just now I mentioned for the detail, okay? So if you give the stimulus to one eye, okay, this is carried by the optic nerve, second cranial nerve, and then reach to the optic chiasma. From the optic chiasma, they reach to the, this is red color. This is the optic nerve. From the optic chiasma, the red color, no, this is the sensory. Sorry, so they reach the, no, they reach the here. So this is called the pretector nuclei, okay? First, they reach the pretector nuclei. From the pretector nuclei, both fibers are coming out from the pretector nuclei. So these both fibers are reached to accessory oculomotor nuclei. They call the name is Edinger-Westphal nuclei. So from the Edinger-Westphal nuclei, this is the motor. The blue color is the motor. This is the motor 2 motor fiber. Okay, so this motor fiber is called oculomotor, third cranial nerve. And then they reach to the ciliary ganglion. This ciliary ganglion is the parasympathetic ganglion. So we say third cranial nerve, parasympathetic portions of third cranial nerve, because this is the ciliary ganglion, is the parasympathetic ganglion. They integrate at the ciliary ganglion first, and then this fiber is the postganglionic fiber. They directly control the tuber constrictor muscle. This is the whole process for how the pupillary light reflects. Okay, so we start with the light stimulation. The first one is we start the retina. All the visions are received by the receptor. Where the locations of the receptor for the eye. The receptor for the eye is called, what is the name of the receptor for vision? Photoreceptor. Where is the location of the photoreceptor? Retina. Photoreceptor. Okay. So light stimulates the retina, photoreceptor. So the impulses are carried through the optic nerve, this is the sensory nerve. Integrating center is midbrain. Midbrain, they first sign up at the pretector nuclei. This is the pretector nuclei on both sides. Okay? And then project fiber bilaterally to the Edinger-Westphal nuclei. This is the Edinger-Westphal nuclei. In here, I mentioned only one side. If I draw this one, both sides will be very messy, so I show only one side. So this is the Edinger-Westphal nuclei. So from the fiber from Edinger-Westphal is the efferent fiber, motor efferent, parasympathetic fiber. In third cranial nerve, they sign up at the ciliary ganglion. From the ciliary ganglion, enter the eye through the ciliary nerve. This is the postganglionic fiber. Final is pupillary constrictor muscle. This is the effector organ of the iris and muscle, tuber constriction. Remember how many steps? 5 steps. So I give you 5 marks. Okay? If you forgot one step, you can get only 4 marks. Okay? Okay, so what are the effects of parasympathetic, sympathetic? Remember, sympathetic and parasympathetic for the ANS, fight or flight. During sympathetic is pupil constriction or pupil dilation. Sympathetic, pupil dilation, fight or flight. You have more vision. For running, you cannot pupil constrict during fight or flight. Pupil dilate. So sympathetic is pupil. Sympathetic is pupil dilate or pupil constrict. Sympathetic is fight or flight is sympathetic. So sympathetic is pupil dilate. So during our time, during our medical student life, some of our friends are very active, hyper, you know the hyper? So we say something, they are very clever, very smart, And so at the back of them we say they are very hyper, So hypers are sometimes we say the sympathetic overactivity. You are very much active, right? So sympathetic is all are fight or flight, all are stimulation effect. Okay? So this is pupil constriction. This is pupil dilation. Okay. So pupil, we have two types of muscle. Okay. So this is the radial muscle. This is the scapular muscle. Okay. So this is for the pupil. This is for the iris muscle. Okay. You know, sometimes nowadays some of the girls they try to make their iris color, the blue color or green color, something like that, right? So this is the iris color. So this is the radial muscle of the iris. This is the scapular muscle of the iris. Okay. So parasympathetic stimulation is to the scapular muscle. So scapular muscle stimulation causes pupil constriction. This is the radial muscle. Radial muscle is by means of sympathetic. Sympathetic stimulation is radial muscle. Contraction is pupil dilate. Understand? Understand? Okay? Okay, so this is the visualization. Visualization is not much important. Just only if you see that something, you have to make fixing on that side. You have to make a fix or stabilize. A reflex movement of the eye that stabilize the image on the retina during the head movement. So this is by means of the integrating center at the midbrain. Okay, next is the form. So what is the functions of the form? Horn is also important for the cranial nerve, fifth cranial nerve, sixth cranial nerve. Mostly these fifth and sixth are important for the eye movement, corneal reflex. So this eye movement, this is corneal movement, also the cranial nerve, facial nerve nuclei are also located in the horn. Also the cranial nerve, vestibular ganglia is also the horn. Also for the two important control centers, pneumotexis and myosis. So these all are functions from the horn. Okay. Okay, this is the corneal reflex. You know the corneal reflex? You can test your corneal reflex yourself. Ask the subject to gaze into distance. Okay, you look a little bit further distance, and then you use the, normally you can use the cotton wool, no? And lightly touch with the fine hair or cotton wool at the lateral edge of the cornea, lateral edge of the white area, not the black area, white area. Not at the conjunctival margin. So what will happen? What will happen? Close the eye. Oh, this is the response, right? Okay. Now, protective response because our body nature is protected closure of the eye. Okay. You see like that? Okay. Okay. So this is corneal reflex by means of the horn integrating center. Okay. And then next is the functions of medulla oblongata. Actually, medulla oblongata is the most important organ compared with the brain and bone. Because of the respiratory, cardiac, physiological center is located at the medulla oblongata. So anatomy is at the floor of the fourth ventricle. All the vital centers are located. Okay. As well as all the visceral reflexes, gagging reflex, coughing, sneezing, degradation reflex, vomiting reflex. All these control centers are located in the medulla oblongata. Also, the control of the posterior reflexes, stretch reflex, tonic liberty, tonic neck reflex, also are integrated at the medulla oblongata. I will mention this one in later my lecture. Okay, so medulla oblongata serves as the conduction pathway from the periphery to the CNS, from the CNS to the periphery, because it contains the descending motor fiber, decussation of the pyramidal tract, motor decussation, and also the rubrospinal tract. Also, they receive the ascending sensory fiber, decussate, and also the lateral spinal nervous tract, and also the dorsal and ventral spinal cerebral tract. So, also they serve as a conductive function, they receive all the sensory fiber as well as the motor fiber. Medulla oblongata also contains the cranial nerve nuclei of 9, 10, 11, 12 cranial. So these all functions are integrated at the medulla oblongata. So means that all these functions are findings of medulla oblongata. Okay. The last one is the reticular formation, RAS system. What is the RAS? Actually, in our brain, you cannot localize. This is exactly the REM system. Cannot. Because REM system is a very much widespread area located throughout the brainstem, and all the information are received from the whole cerebral cortex, as well as they send all the information in the whole cerebral cortex, because it is a arousal state or alertness state of all. Okay? So, it is a complex network of nuclear and non-fibrous unit metaphor for brain, nervous, hypothalamus. Cannot say the exact location. Okay? Majority is in the brainstem. See here, they set all the impulses to the whole neocortex. So they function as a reticular activating system. The major function is alert, conscious awareness of the body. Okay? So, what is the functions of the RAS? The first function is arouse, activate the cerebral cortex, to promote alertness, ability to direct attention towards the specific event, and control the muscle stroke, and control the sleep, wakefulness cycle. Okay, so this one is, I mentioned you just overall, I think you have another lecture regarding for this case. They were mentioned together. So, this is the overall A. So this is the overall for the NREM and REM sleep. You know what is REM sleep? What is NREM sleep? Okay? Active dreaming are also in NREM or REM. Active dreaming. REM sleep. REM sleep is a sound sleep or NREM is a sound sleep. REM sleep is a sound or a sound sleep. NREM is a sound sleep. REM is a rapid eye movement. So rapid eye movement is, for example, throughout the sleep cycle, the whole night sleep cycle, but more nearer to the morning, mostly sleep cycles are occupied by the REM. Because people are ready to wake up. Okay? For example, if they're sleeping in the seminar room, it is a REM or NREM. REM sleeping in the seminar room, lecture room. It's Is it a sound sleep or just awareness? Okay, so it depends. Okay, so that's what I'm joking. Okay, so if you want to check is it the REM, because you have the sleep cycle, I think we have 4 stages of sleep cycle, pattern, regular pattern. So, I think during our time, one of our lecturers told me that, for example, we have depend on our body physiology function, depend on the REM and REM. I have one remember that, for example, growth hormone production. Growth hormone production is also throughout this REM sleep. So our lecturer said, if you become a mother, if you want to grow up your child, okay, so you wake up your child very frequently because you want to promote the REM sleep, right? Because REM sleep is for the growth hormone production, like that. Okay, so for the EEG, electroencephalogram, for the NREM, it shows a slow wave. For the REM, it has an alert pattern, EEG. So motor activities are, we have some motor activity shifting. In here, REM has no motor. Even though it is a not sound sleep, they have no motor movement. But for the heart rate, blood pressure is, this REM is irregular. This is a little bit minor changes. For the dreaming, because you got a very deep sound sleep, rarely dreaming. The dreaming is in the REM. Do you remember that sometimes if we wake up from the bed, we have so many dreaming the whole night. Every day we are not get enough sleep, isn't it? Because of you have a lot of REM. You cannot get the sound sleep. Sometimes we didn't get any dreaming. Very sound sleep. Like that. Okay, so this is like that. So the arousal state, see here, even though it is a NREM because they try to get body sound sleep. So sometimes it is hot and aroused, but upright awake on the So most of the sleep diet, this is a normal person. So NREM is important for the sound sleep because our body needs rest, right? So 80%, this is only 20%. But some of the person insomnia, they cannot sleep well at night, right? So their REM portion are too high. So 50 some of the person, other important characteristics. So don't worry, this REM is totally not concerned with the medical doctor. We have a lot of this one and REM. Whenever the duty in the hospital, even though in the chair we can sleep, we can get this one and REM, no problem. Because we are so tired. Even in the sitting in the chair in the hospital, okay, only 30 minutes is enough. We can get this one and REM. Okay? Okay. Any questions? Any questions? No. So, understand? So, this brainstem function is very much important, no? You must know almost all, no? So, what are the functions of brainstem? What are the functions of individual?